calling the joint committee on, the Senate Committee on Health and Human Services and the House Committee on Health and Homelessness, informational briefing for October 4th, 2023, 12 o'clock noon, regarding the House Concurrent Resolution 205 that passed in the 2023 session. For the Senate, it is myself, that's it, Senator Joyce and Buenaventura, and for the House it is.
Good afternoon, Della Volati, Chair for the Committee on Health and Homelessness, and I'm joined by Vice Chair Jenna Takaneuchi.
Okay, so to be concise, this is regarding a concurrent resolution on recognizing and supporting ongoing collaborative efforts by state agencies and private organizations to implement the HEP-free 2030 statewide strategy to eliminate viral hepatitis types A, B, and C in Hawaii. The purpose of the briefing is to receive updates and recommendations from the Department of Health and HEP-free Hawaii community partners on HEP-free 2030, the statewide viral hepatitis elimination strategy and its impact for the state, per House Concurrent Resolution 205-2023. Hepatitis B and C are both preventable and treatable, but they cause high death rates for Hawaii residents, especially people of Asian and or Pacific Islander descent. For example, recent data shows life expectancy decreases by 20 years for people diagnosed with hepatitis C in Hawaii. To address this epidemic, Department of Health partners closely with the HEP-free Hawaii Coalition to implement HEP-free 2030, the Hawaii Hepatitis Elimination Strategy 2020 to 2030, to eliminate hepatitis in the state by 2030. This plan aims to prevent infection and death due to viral hepatitis for all Hawaii citizens. Following persons have been invited to participate, and first up, I see is I had Timothy McCormick, but
yes,
okay,
that's me.
Timothy
Yep.
McCormick, Chief Department of Health Harm Reduction Services Branch, and I believe with him is Thadia Spam, a Viral Hepatitis Prevention Coordinator, Department of Health Harm Reduction Services Branch. And I understand we have 2 hours for this hearing, but I'm hoping that amongst all of you, you could limit your time to 1 hour collectively so that there will be times for questions. So anything else, Chair Bellotti?
None from me, but we are joined by your colleague, Senator Moriwaki, and Representative Burt Kobayashi walking into the room right now.
Okay, thank you very much for reminding me. Okay, please proceed, Dr. McCormick.
Not doctor, just Tim is fine. Good afternoon, Senator San Buenaventura, Representative Bellotti, and representatives and senators on the committee. I'm Tim McCormick. I'm with the Department of Health's Harm Reduction Services Branch, which has responsibility for HIV, sexually transmitted infections, and adult viral hepatitis. I want to thank you for your invitation and for your attention to this important issue. I'm going to start with some background information on hepatitis B and C. This slide shows the burden of hepatitis B in the 8-year period in the US from 2014 to 2021. The orange line shows reported cases of acute hepatitis B, which in 2021 were approximately 2,000, and that was based on 47 states reporting. Acute hepatitis B is vastly underreported, and the blue bars show CDC's estimate of total acute cases, which in 2021 was approximately 13,000. Next slide. So there are significant racial and ethnic disparities in hepatitis B. Looking at chronic hepatitis B, the rate in 2021 was 14 times higher for non-Hispanic, Asian, and Pacific Islanders compared to non-Hispanic Caucasians. Before we move on, I just want to acknowledge that unfortunately the federal data collapses Asian, Native Hawaiian, and non-Hawaiian Pacific Islanders. And as we move forward, starting to collect better case data, we will certainly have race and ethnicity data in more granular categories. Hepatitis B is vaccine preventable. Hepatitis B is spread through contact with blood and bodily fluids, leads to liver failure and liver cancer. Vaccination has long been recommended for infants and children, and we're now seeing very high rates of vaccination up to age groups in the mid-30s because of decades of school-based vaccination programs. Vaccination is now also recommended for adults 19 to 59, and it's also recommended in adults 60 and over with risk factors. Even with wide availability of vaccination, screening is critical, and all adults are now recommended to be screened at least once. People can have hepatitis B for a long time with no symptoms, and early identification of infection is important in part because treatment is available. I'm going to move on now to hepatitis C. A similar slide to the one that we looked at for hepatitis B. This is the burden of hepatitis B in the US in the same 8-year period, 2014 to 2021. Again, the orange line shows reported cases of acute hepatitis C, which in 2021 were approximately 5,000, and that was based on reporting from just 42 states. Like hepatitis B, acute cases of hepatitis C are vastly underreported, and here again, the blue bars are CDC's estimate of total acute cases, which in 2021 was approximately 70,000. So from 2014 to 2020, cases of acute hepatitis C doubled. Looking at acute hepatitis C by age, in recent years, the rate has been increasing in all age groups over 30, and the rate is highest in the 30 to 39-year-old age group. There is no vaccine for hepatitis C, but there is very effective and well-tolerated treatment that's been available for almost a decade. These treatments have a very high rate of curing hepatitis C with as little as 8 weeks of treatment. In spite of this, just 1 in 3 adults diagnosed with hepatitis C in the US have been cured. Among individuals without health insurance, that's only 1 in 4. It's also 1 in 4 among individuals who are under 40. And if you look at individuals who are both under 40 and uninsured, the rate of cure is just 1 in 6. So there are many missed opportunities there. Moving on to the burden of hepatitis C in Hawaii, we have limited data on incidence and prevalence cases due to limited disease surveillance. I'll talk a little bit more about that later. But there are some very concerning indicators from other sources. So we know that hepatitis B and C account for 2/3 of cases of liver cancer in the state, and we have a high rate of liver cancer and related deaths compared to the US as a whole. Looking at mortality data for 2016 to 2017, Hawaii residents with Hep C died on average 20 years earlier than state residents who did not have hepatitis C, as Senator San Buenaventura mentioned earlier. Looking at hepatitis C related deaths in that same 2016-2017 period by race and ethnicity, Hawaii was the state with the highest proportion of Native Hawaiian, Pacific Islander, and Asians among hepatitis C related deaths. We also have high rates of Hep B related deaths. In 2019, Hawaii had Hep B mortality rate of 1.17 per 100,000 population. That's nearly 3 times the US rate of 0.42 per 100,000. Among state residents who identify as Asian or Pacific Islander, Hep B mortality was up to 1.4 times the state average from 2000 to 2020. So a little bit about the infrastructure within the Department of Health to respond to hepatitis. And before I move on, I do want to mention that this does not include childhood vaccination efforts. So exclusive of that, CDC has provided funding for approximately 20 years. It's very modest funding. It's currently been about $115,000 a year to support a hepatitis coordinator, and there have been no additional funds from that cooperative agreement to support services. In recent years, we've used state general funds, generally year-end savings from elsewhere in our program, to support some level of vaccination services and education. And in recent years, it's been about $75,000 a year that we've been able to come up with. Beginning in 2000, CDC added an additional $123,000 a year to our cooperative agreement to support increased capacity for hepatitis surveillance. So we requested and got approved for a special exempt project, which allowed us to create a position. That position has been established, and we are currently conducting interviews, and this will be an epidemiologist to coordinate hepatitis surveillance activities in the state. So hepatitis B and C have long been reportable, and these reports do come into the Department of Health, but we've had no capacity to use this data for surveillance activities. And this new funding, the funding for this new position, will allow us to increase our capacity for Hep B and C surveillance, and we'll begin to develop a better picture of the true burden of hepatitis B and C in Hawaii. One of the keys to having any impact with such modest funding has certainly been the strong collaboration between the Department of Health and the community. And at this point, I'm going to turn it over to Thaddeus, who will tell you about Hep-Free Hawaii hepatitis elimination strategy, which is really a result of the strong collaboration between Department of Health and the community. I guess I can pause for questions here before we move on if you'd like.
I guess are there any questions, members? I have one question. What is it? Is it a genetic propensity that makes Asian and Pacific Islanders more prone to have Hep B, Hep C, Hep-related symptoms and illnesses?
That's a great question. Primarily, we think it's the relatively high rates of hepatitis B in Asia and the Pacific, and there's definitely a link to immigration. So what we often see is even US-born children of immigrant parents are more likely to have hepatitis B at the time of birth, often without knowing it. Sometimes they go on to get vaccinated before going to school and don't realize for many years that they've been living with hepatitis B. So it's really about the global distribution of the disease primarily.
So what about multi-generational? I mean, Sansei, third or fourth generation. Do you see a decrease, or have you folks gone down to that granular level?
We certainly don't have that kind of information for Hawaii data. I don't know, Thaddeus, can you speak to US data on that?
Well, I think what might be helpful is there is data from Micronesia where before they didn't have childhood vaccines available in a really systematic way, but after implementation of that, it went from about 8% prevalence to 2% among the younger generation. So it really is when implemented correctly, there are interventions that can reduce that intergenerationally, but without any intervention, it can continue to spread for hepatitis B.
So
Yeah.
Go ahead.
Thaddeus, can I just inject a few comments? This is Dr. Yeah, this is Dr. Naoki
I'm
Sai.
sorry,
Yeah,
you're gonna need to identify yourself because we don't know who you
Yes.
are. Sorry.
Yeah, this is Dr. Naoki Sai. I will be presenting after Thaddeus in this presentation, but I think I want to answer your question regarding
That
why
would be good.
Asian Pacific Islander have it. I think the number one reason is hepatitis B pretty much transmitted from mother to child. That is the most common transmission route.
So it's a
the
genetic
problem-
propensity then?
No,
No?
it's not a genetic
So mother
propensity.
would have it.
Right, and mother would have a lot of virus in their blood. And at the time when the mother is delivering the babies, that's when the mother infected the babies. And baby will carry the virus for life.
Oh.
And the way to stop that is to do vaccinations. I think the state has been doing very well, giving vaccines for prevent the baby from getting infection from their mother. And that's what Thaddeus was talking about, stopping that transmission right from the beginning. And I think the rate of infection is getting down significantly in the hepatitis B in any place where vaccination is carried out very well. And that's what's happened here in our state, that we had a very good prevention and control in place for that particular reasons.
Okay, thank you.
But
So
people who are
Yeah.
from the South Pacific, they don't have that mechanism. That's why they keep having more and more people getting infected.
Lack of vaccines. Okay, Senator Moriwaki.
So my question was, it was whether it's genetic, but if in fact it's transmitted and the mother gets it, how does the mother get it?
Yeah.
And is it just a vaccine, which seems like it's after the fact or before the fact? But if the mother already has it, how did she get it?
Yes.
So great question. So typically it will be from her mother. So you're speaking of intergenerational. So a lot of them, since they didn't have access
How
to
does her
vaccine,
mother get it?
it's actually endemic to Asia and the Pacific. So that's where Hep B is
So the
known.
virus is contracted
Right.
wherever they're living.
Yeah, I think Dr. Sai even mentioned one time there was like a mummy in Korea that had hepatitis B in it, so it's been just in that area of the world for a long time.
And one more question.
Oh, go
What
ahead,
is the
Senator
difference
Moriwaki.
between Hep B and Hep C? And you say if you have hepatitis B,
Mhm.
you can get hepatitis C. So what is the difference, and what are the symptoms, and what do we do about it?
Great question. So hepatitis B and C, they both affect the liver, but they're completely separate viruses. So hepatitis B actually transmits a similar way to HIV. So a mother to child, bloodborne and sexual, and it's incurable, like Dr. Sai had mentioned. So once it becomes chronic, all you can take is medication to suppress the virus to reduce, liver disease, liver cancer, and mortality, right? Hepatitis C, on the other hand, separate virus, mostly spread from blood to blood, and it's curable, as Tim alluded to as well. So unlike Hep B, if you get it, you can be cured of it, but also there's no vaccine and no immunity. So if you get cured of it, you can catch it again. So they almost kind of work in different ways. And some people will be exposed to both, typically due to bloodborne transmission, right? Since they both can be spread by blood.
So one more question. So
Yeah.
how do you know the difference between B and C? Is it through blood test or?
Correct, yeah. So it would have to be through a blood test. And this is why we see that higher rates of Hep B mortality that Tim mentioned, is because those who didn't get the vaccine aren't screened in time. And then by the time they are screened, if they are screened, then the Hep B might have progressed to liver disease, liver cancer, or death, right? So that's what we're trying to work on as well, is for that older cohort who didn't get the vaccine, how can we address their needs as well?
So you're saying B is not treatable?
B is not treatable, B is treatable but not curable. Yeah. So if we get them the treatment, then we can suppress the virus and reduce those liver disease outcomes.
Any other questions, Senate?
Thank you.
And I'm assuming House?
Questions?
Okay, I have a follow-up question, sorry.
Yeah.
My understanding of Hep C is that the reason why it's more prevalent for those who are older was the old-time drug users. Because Hep C wasn't considered an illness until sometime in the 90s, right?
Mhm.
I mean, before that, there wasn't a disease called Hep C.
It hadn't been identified.
It wasn't identified. So unlike Hep B, which is endemic to countries, Hep C is, I don't know what word to use, not endemic, but more prone to former drug users, was my understanding.
Since it's bloodborne, in injection drug use, it is a really common transmission mode, and it's quite infectious. So people don't have to have much of a history of injection drug use. It can be very, just a few instances, and that puts them at significantly higher risk of infection.
So are they also more prevalent, is Hep C also more prevalent in Asian and Pacific Islander, or is it mostly Hep B because it's endemic to those countries?
So Hep B is more prevalent in Asia and the Pacific, with certain exceptions, like Vietnam has higher rates of both Hep B and Hep C. And like Tim said, it's really efficiently transmitted through blood to blood, so it can live in a syringe for 63 days, basically. So any sort of drug or needle exposure, even as one time, can efficiently transmit hepatitis C. So any sharing of equipment.
So Hep C is not more prevalent on Asian and Pacific Islander?
Not necessarily, not in the same way that we're talking about with
But Hep
hepatitis
B,
B.
okay.
Yeah, correct.
Thank you.
Thank you.
Oh, Representative Kobayashi.
You're talking about what I would consider real small amounts of money,
Yeah.
like $75,000 state funds.
Yes.
I mean, gee, it's not worth sneezing over.
We've done a lot with that money.
But, I mean,
Yes.
could you use more, and to what effect?
I think when you see more details on the hepatitis elimination strategy, it'll become clearer. Certainly there is a lot more to be done, and hepatitis C in particular is a winnable battle. It's curable. There's a lot that we could be doing to really significantly reduce hepatitis C. Once somebody is cured of hepatitis C, they can't spread it to anybody else. So there's really an opportunity here to make a huge public health difference in these diseases.
Okay.
Okay, any other questions? Okay, so let's go on to the next speaker. I guess that's you,
Yep.
Dr.
Thank you.
Van.
Yeah, and not a doctor either. Thank you,
Okay.
Tim. So Thaddeus Pham, he, him. I'm the viral hepatitis prevention coordinator, which is a mouthful, so you can just call me Thaddeus. I can talk fast and voluminously, so you can always stop me at any point. But Tim ended, I think, with a perfect note. And actually, Representative Kobayashi, thank you for pointing that out. We've been able to do a lot with a little, and I think primarily because we're based in Hawaii, we really leaned on our relational capital, I would say. And we are really rich in our relationships. So this is just noting, I see quite a few folks from Hep Free Hawaii today. It's our statewide coalition that's been around for over 12 years, and is really just convening people and using their wisdom to move forward. So I'm gonna share with you our statewide strategy, which is Hep Free 2030, which we're trying to use to eliminate hepatitis in Hawaii by, I guess, in the next 7 years. So no pressure on us. So strategy process. So I do want to acknowledge we are very community driven and community centered. Dr. Tsai and Dr. Baumgartner are also part of the coalition. But this started in 2019, pre-pandemic. In July, we convened 45 local stakeholders and really got down together and said, what do we need to do to eliminate hepatitis in the next 10 years? Then, despite COVID, and with the urging of our community, we were able to convene over 24 formal meetings, not including all the informal meetings, sitting in the back of a syringe exchange van, texting with people with lived experience, and talk to over 160 people for them to inform us at the state on what should be done to eliminate hepatitis. So a truly community-driven effort. By the end of those 12 months, we released Hep Free 2030 in 2020, and we came up with a very novel way of approaching hepatitis, both in Hawaii, but also across the state, across the US. So we look at 5 priority areas, which I'll show you, and we created strategic directions. As Tim alluded to, we don't have surveillance data, so we wanted to have a direction, even though we couldn't have a specific number yet. And I think this is really the most powerful part for us, is we created what we call micro-elimination opportunities. So we turn to our community partners and say, what works for you in your local community, and how can we make that work better, right? So here we borrow from our tech industry, where we fail fast and we amplify good. So if it's not working, let's move on. If it's working, let's amplify that as much as possible, right? And because it's community proposed, the buy-in is already there. So we can move forward fairly quickly in terms of community buy-in. And I'll share some examples for you folks as well. Every time we do our work, we base it in our values, which we decided with our community. So I'm going to name them here because this also helps orient us really well when we move forward. So our values are to reduce harm, so harm reduction. How do we kind of center community voice? We really promote social justice because we know hepatitis, because it's affecting people with lived experience, people who are houseless, people who are born in other countries. This really becomes a justice issue as much as a health issue. And because of that work, we do intersectional work. So some of you might see me or Heather working on opioid issues, on housing issues, on immigrant rights issues, on LGBTQ issues, because all of those intersect with hepatitis. And finally, of course, we approach this with aloha, so we acknowledge the place and the culture in which we work as well. So that helps us orient. And I will just briefly just read this quote from one of our steering committee members. Our fight against hepatitis is also a fight against stigma, discrimination, and inequity. So that justice component comes in again. I'm going to read the mission and vision to you. Just kidding, I'm not going to do that. But just to note that the whole point, right, as Tim showed, is to save lives, right? Is to give people 20 years back on their life, if possible, right? To make sure that our people who are Asian Pacific Islanders are not dying more than the rest of the state. So how do we save those lives? And this is the 5 priorities that I mentioned, and I'll go over each one and give you a highlight of one community suggestion. I presented recently on this, and I ended up presenting like 25 different projects that are ongoing concurrently with that 75,000 or less, right? Just on working with our partners. So for awareness and education, here's some of the strategic directions, and this is probably our shining star for education right now, which can also, I will note, be used for other disease states. So hepatitis C echo is case-based telelearning for local providers with local experts. Dr. Tsai and Dr. Bumgardner are two of our faculty on it. So what this is any local provider, including doctors, nurses, but also pharmacists, caseworkers, any part of the healthcare team can join on for free and talk to local experts, present a case on hepatitis, and get feedback directly. This happens every Monday until November 20th, and we've had 60 healthcare providers join every week, approximately. So really a fantastic way to amplify our existing wisdom to new and other providers who are interested. And as you can imagine too, this really is supportive of our neighbor island and rural providers. So a lot of those folks from other islands also join. Clinical services, I'll note that this is priority 2 out of 5. So this is only 20% of our strategy is focused only on clinical services, really showing the systems level work that we're doing. So we do work directly with our correctional systems. We have an MOA with public safety to integrate into all of their sites. We've trained 70 of their healthcare staff. We're giving them an opportunity with our grant with the CDC to avail themselves of cheaper medications through this MOA so they can get 340B pricing. Otherwise, public safety sites aren't eligible for that 340B, really deeply discounted drug pricing. So we're working with them on that as well. And we also connect them with our community partners for post-release transitions to care, right? So if they're gonna be released, how do we ensure that they still get the care that they need in a timely way? This is really big, especially, I would say, for our Maui jails and our Maui partners, despite the ongoing issues with the wildfires. Finally, number 3 is policy. Heather will speak to this later, but we want to mahalo our MedQuest members. So we work also with MedQuest. They put out a memo to reduce barriers to treatment so folks on MedQuest can get access to the cure more easily. Implementation has been rocky, and we're still continuing to talk with them, and Heather can share more about that, and I think our clinical providers as well. Equity is really important for us. That's why it's a separate column, a separate priority. And I think this is also really relevant to Hawaii because it's culturally congruent, right? How do we create talk story opportunities that uplift people with lived experience? This is Oki and her son Richard, who are both living with hepatitis B. And so we highlight their stories, we pay them for their time, and they also become our new leaders and champions, right? So it's not just a health department person talking about hepatitis, but really someone who's lived through it, who is the leader. And Kenson's gonna share later today as a Hep B storyteller for the Marshallese community. And finally, number 5, one of my mentors always told me, don't get mad, get data. But we can get mad and get data too, so it's not mutually exclusive. But Tim shared a bunch of numbers data. What we also wanna be mindful of is, again, to be culturally congruent in Hawaii. The health department released a report earlier this year on qualitative data, right? Talk story data. And this is a methodology that is legitimized in all sorts of research. So this is an opportunity where we spoke with people who are actively using drugs in Chinatown to get their perspective on how to treat hepatitis C, right? Because if we propose something and they don't even think it's a good idea, it won't work, right? So they gave us several ideas, which we put in a 1-pager, so you don't have to read all 30 pages. And they said we should use syringe exchange as the hub for care because they trust it and it's been around for 30 years. We should provide education that is short, no more pamphlets please. They want half a page, 1 or 2 sentences, very visual. So really concrete ideas on how we can work with this community for several issues. And then finally, these are our calls to action just in general for our coalition, which is always to join, to follow on social media, and to really uplift voices. But I'm gonna stop here before I turn it over to Dr. Tsai to see if you folks have any questions about HEPRI 2030 or our coalition working over the past 12 years.
So any questions from the Senate? Senator Moriwaki.
You said that this educational program will end in November. Why?
So that's a really good question. So the funding is limited, but what we do is.
Is that federal funding or state funding? Or what?
It was federal funding that came through the state. But the good news is that we also decided to make it short term. So this one is 12 sessions because it provides, creates like almost like a cohort of providers that feel really safe. And we notice if we just keep it going for in perpetuity, people kind of fall off and there's less urgency. So providing it free, including CE credits over a short term, there's more of an, an excitement about joining it. And then every year so far, we've been able to just do the next round. So we have like Hep B last year, we had a medication for opioid use disorder the previous year, and we had Hep C the year before that.
Are there new people coming in so the information is there, or is it there so anybody can come in still, even if they don't come in on a Monday? Or?
Yeah. So it's posted on a website, so it's durable education, and we also provide recordings as well. But I guess the draw is that if you do attend in live, then you get CE credits for that. So for our providers, especially, that's a big draw.
So going forward, sustainability, because education is important, and you update it, or is there a cost to updating it to keep it going forward so that you're constantly evolving and adding new information, new research data?
Yeah, so I mean, the cost is relatively small to run like an echo. Like a 16-week echo is around $20,000, which is pretty small given all the coordination that happens. So the hope is that we will get funding for the following year. And we're speaking with our colleagues in the health department who funded this before to see if we can continue it again.
So it's an ongoing kind of program, because it seems that education is critical.
Yeah, and I'll note that when we first started, it was 20 people. I think our first Hep C echo 3 years ago, and now it's 60 people regularly. So I think we've also established enough of a reputation where they know the quality is good as well.
Any other questions from the Senate?
Yeah, just one more. Is it
Yeah.
only on Hep C, or is it also B, or why is it only focused on Hep C?
So each time we've done it, we focus on one of them to kind of have a deep dive. So last year's was hepatitis B.
Oh, okay.
Yeah, and many of the providers who are interested end up joining us for the next one as well.
And that's durable. It's still on some kind of website.
Yeah, it's still on the website as well. Yeah.
Thank you, Chair.
Okay, for the House.
No, not yet.
Okay, I have one question. I understand that this time around it's for Hep C, but for Hep B, since infection seems to be, I remember the restaurant scares in the prior years. Shouldn't there be also education and testing for like restaurant workers, especially immigrants, or is that something that will be discussed later on?
So actually,
Because I see, when I look at your slides, I see recommended all testing for all correctional settings, but that's for Hep C. But what about Hep B and restaurant workers and?
good question. So the restaurant outbreak was actually hepatitis A,
Oh,
which
sorry.
is another one that we work on too, which is a separate virus. So Hep A is usually acute. So usually testing doesn't really help because if you have it, you pretty much are having it at that
Okay.
moment. But the good news is with Hep B and Hep C, the recommendation from CDC is for all adults to get tested one time, regardless of risk, inclusive of restaurant workers anyway. So we're trying to work with that to promote that awareness as well.
Okay,
Yeah.
thank you, sorry.
Isn't there some requirements for Hep testing for workers?
For healthcare providers, there is recommendation from most sites to get hepatitis B vaccination and then to show that you have immunity. So there's a titer test for Hep B. There's no requirement for Hep C, and I think Hep A is recommended for healthcare workers, but not as required as hepatitis B.
Is there a requirement for school-based workers?
School-based workers? I can follow up on that. I know school-based, I was about to say school-based children. So students, yes.
Yeah.
There is a Hep A and B recommendation.
Okay.
But I can follow up about school-based workers.
I think the question is requirements though, rather than just recommendations.
Okay. We will also work with DOE, so I can follow up with our DOE colleagues to find out for you, and I can email that to you afterwards.
Thank you.
Thank you. Okay, any other questions? Okay, so next up, we have,
Were you finished?
Yeah, I'm done.
Okay.
Yeah. I mean, next we have
Yeah, we have Dr. Sai, who is on
Hi.
Zoom for us. Dr. Sai, please identify yourself and proceed.
Okay, thank you. I thank you for the opportunity to be here to present a clinical perspective. I am a hepatologist, and I actually started Liver Center, the only one and the first liver center in the state back in 1992. And I also were involved in starting the first and still first only liver transplant program with Dr. Linda Wong, who is a transplant surgeon. Both of us worked together also since 1992. So I have probably close to 30 years of experience dealing with viral hepatitis, in particular hepatitis B and hepatitis C. And I'm not going to go through a lot of clinical epidemiology data because Tim and Thaddeus has really described it very well and nothing more. But this next two slides, what I would like to do is just to show that Hawaii is still at a high rate of death from hepatitis C, which is one of the focal points that we have, because this disease is very treatable with a very safe medication and a very short course of therapy and a very high rate of a cure. Next slide. And it's the same slide, but more detail. But if you look at the number 4 from Button, Hawaii, over the years, we're hovering around 2 to 3% of the rate of death from hepatitis C. So it still continues to be a problem. Next slide. And one of the comments was made earlier about that hepatitis C are mostly in the older generation, what we call the baby boomer. That is not true nowadays because we have a very strong upticks of hepatitis C, both acute and chronic, in the younger generation between year 20 to 49. And that's what you see the first peak. The taller one is for men and the smaller peak is for women. So you can see that peak is kind of overtaking the older generations because the older generation is being treated and they are getting much better. The problem of this new generation is because of the epidemic of drug usage, particularly IV drug usage. And that is the urgency why federal government was really want to focus on these issues to get rid of hepatitis C. And it has been recommended by both CDC and U.S. Preventive Service Task Force, which is a very important policy maker, to recommend that anybody who between age 18 to 79 should have at least once lifetime to check for hepatitis C. But also for those people who have risk of getting recurrent infection to be tested from time to time. And this is a very strong recommendation from USPSTF because that is pretty much accepted as a standard of care in all the healthcare system. Next slide. And as for the treatment for hepatitis C, this is a statement that has been put on many years by our liver society. That's the American Association for the Study of Liver Disease and the Infectious Disease Society of America. What they say is that anybody who have evidence of chronic hepatitis infection should be considered for treatment. For those who have a short lifespan, then you don't want to go and to treat them because of other comorbid condition and lifespan. But other than that, anybody who have chronic hepatitis C should be considered for therapy. Next slide. The current treatments are 2 that is commercially available, as shown in here. One is to be taken 3 tablets a day, once a day for 8 weeks. And then the other one taking 1 tablet a day, once a day for 12 weeks. Next slide. And this is the efficacy of those treatments. I'm just using one slide for one special medications. If you look at the left side of the graph, total number of patients is more than 1,500 patients, and they're actually reaching between 98 to 97% of cure. The word SVR12 here means cure, meaning that once they are treated, they are clear of the virus, and the virus is no longer a problem for them. And that is a most impressive success in all my career of any disease, that they have a cure for this. And even for liver patient with cirrhosis, that is in the light blue car. So it's across the board with all the genotype. You are talking about a very high rate of success of eradication or eliminations. Next slide. And this is shown on this graph. I just want you to focus on that dark blue color line. The first drug that is developed for oral use, just taken by mouse, is about 2013. And this graph is the patient who have liver disease and have death. And you can see the death starting to drop after 2013. And so this is a very effective treatment and have a significant clinical impact in human life. And I think Thaddeus mentioned it very well, that in Hawaii, we need to do a lot of catch up, because we're going to have to help those people to extend their lifespan with the treatment. Next slide. So what are the barriers for us at this time for Hep C treatments? One is prior authorization, because the drug is relatively expensive, and I can understand that. But this PA process really hinder a lot of providers to treat hepatitis C. And so we think that the opportunity is to remove pre-authorization, which is being done by the state Medicaid, MedQuest program, but we have some detail to iron out with the insurance company. And the other one is provider education, which is a very well pointed out by the senator, that we really have to go on the education part to get more providers to get into the actions, to screen patients and to treat them, because the treatment is the best practice for hepatitis C. Next slide. And the second barrier, the other barriers are mostly resource barrier. The funding for medication, I think that is being taken care of, but still a way to go. And funding for health centers and providers to deal with these particular problems is also really needed. And the last one, a lot of the source of the newer hepatitis infection has to do with addictions. And I think if you get rid of Hep C, we also have to work on the source of the problem, and that is the addiction management. And I think funding for that particular part is also very important. Next slide. And I think that's the end of my presentation, and open for questions.
Questions, senators? Senator Moriwaki?
Yeah. The funding, Dr. Tsai, what is addiction management? If you can go back to those slides, and what are the costs that you're looking at, and what are the outcomes if we funded any of those? The medication, is that MedQuest or health center and providers, and the addiction management? And maybe a secondary question to that is, why are the providers reluctant to provide the services?
Thank you, Senator. That is a very good question. The medication itself, the funding for that, it is quite, a funding difficulty for many states and even for private insurance, because they are expensive. But that is getting much better now. There are different ways of dealing with this by different, very innovative way, and there are several states. For instance, Louisiana, in their correction facility system, they innovated with what they call Netflix account. And I don't really understand that, because I'm not an accounting person. I don't
Sorry,
know
doctor,
much
can
about
you
this.
can you repeat that again? It was what?
Yeah.
Funding?
Oh, it is an accounting. It's a knowledge more about the drug accounting and the drug, fee payment. So I'm not an expert on that, but I understand that the funding for the medication is being resolved in different states. But more importantly, recently there is a White House policy trying to get really funding across the board in the nation to provide funding for the medication, because they believe treatment is the key to eliminate hepatitis C. So I hope that answers your question, because I really don't know the amount of money needed, how to resolve that. I think that is more, has to do with, people who are very familiar with the financial support.
So I guess in
But what I'm
relationship
saying-
to that, Dr. Tsai, is the funding, are there sources to fund those, like MedQuest or Medicaid for the state, for our state, those in
Yes.
treatment in our state? And
Yes.
what, I guess then it goes back to the data, how many people need to be treated? And that would follow, but I'm just wondering, is there a steady source of funding for that?
I do believe from my communication with MedQuest is that their funding is not a problem for them at this point in time. They were able to, through their own way, to get funding, and that is what I was told. So what is the way to get a resource for the funding for the medication is something that I cannot answer, because I don't know much about it. But I do know that number one, the federal government is providing funding to the state, and I know that some state, like Louisiana, have started with a very novel way of funding for their medications, and that I think every state is trying to patent that or fashion that to help their own funding source for these medications.
So Thaddeus Pham, I believe, has an answer.
Yeah, well, I can just clarify what Dr. Tsai is speaking to. So he alluded to the Netflix model, which is used, it's
The subscription.
subscription model, exactly, which is used in Washington State and Louisiana, whereby the state government, so Medicaid and sometimes the public safety, will contract with one of the drug providers for a capped rate. So they'll pay a certain amount for a whole bunch of for all drugs, all treatment, and that's all they have to pay, right? So it's more cost saving if they treat a lot of people, right, rather than just one person or something. So that's what he's alluding to. And then the White House is currently trying to put forth legislation federally to that, basically across the entire U.S. for all Medicaid and public safety. So you can imagine what kind of a lift that is also. So we don't know when that will happen.
So the medication funding is not a problem because they're going to be funded across the board, or is that a problem in terms of getting the funds to get the medication to the clients?
I think it's still a consideration when we speak to our local insurance payers in terms of what they say is an issue is the cost of the medication. And then that federal source that I had alluded to they still even haven't drafted legislation to even talk about that. So I don't think that'll be happening anytime
It's a work
soon
in
enough.
progress.
Yeah, especially with government shutdown and all the other issues that are happening on CAP.
So that addiction management, is that a service that also comes under the rubric of being funded by MedQuest, or who would fund that? I'm looking at across the board.
Yeah, well, I would actually defer to Heather Lusk, who might be able to
Oh.
know a little bit more about
Okay.
addiction, because she's been speaking with MedQuest about covering certain services. But I think what Dr. Tsai is mentioning here is covering and supporting more addiction, substance use disorder treatment and resources, which is also not readily available for everyone in Hawaii as well. So I think it would be scaling up multiple things in order to support people for effective hepatitis elimination.
And I guess the follow-on to that is, why are providers reluctant? Is it because of the funding, or is it because of the kind of service? What is the problem in getting more providers to provide the service?
I think one is that they're unfamiliar with it. Two, I think what we hear, and Dr. Tsai and Dr. Baumgartner, please feel free to correct me, but there is, I think, priorities also in terms of capitation and how they're reimbursed, right? So if a provider only has 15 minutes to see their patient and hepatitis is not one of the things that's brought up, their priority is to kind of meet the metrics that are put forth for them from insurance payers. So I think it's also not a priority for them. It's not a quality measure, it's not a quality metric in any way. So there's no incentive money-wise to do more, which was understandable too for our providers in order to be sustainable in their practice. But when we provide education, when we show them that there's an urgency and it affects their patients, then typically they're more willing to do it, especially our providers who are working in community health centers, or I would say neighbor islands and rural areas have seen more of this as well. And Dr. Baumgartner actually works at Hawai'i Island Community Health Center, and she'll be next too, so I'm sure she can speak to that.
She can talk about house.
And I can actually speak to that now if you'd like me to introduce myself, and I can answer that question and then
Okay.
speak to the next part. Would that be okay?
Yes, Dr. Baumgartner.
Okay, perfect. My name is Melissa Baumgartner. I'm a clinical pharmacist and director of pharmacy services at Hawai'i Island Community Health Center. And to your question about why providers may be reluctant to treat hepatitis C, it is not that they're reluctant, it is that there are barriers to their ability to do so. Until the PA or the prior authorization process is resolved, right now our MedQuest plan will not allow a primary care provider to treat hepatitis C without consultation with a specialist. So in order for the prior authorization for the hepatitis C medication to be approved, they have to have consulted with a specialist like Dr. Sai. So that is the barrier right now. And until that process gets ironed out, MedQuest has issued a letter, and they're going to speak about that, and I will not steal Heather Lust's thunder, so I'm going to just push that to the side. But until that process is finalized, that is the biggest barrier to primary care providers treating hepatitis C in our state.
Just a follow-on question, then what is the prior authorization and what is required?
Yes. Let me speak to that. So this is a medication that is very pricey, and by very pricey, I mean one course of therapy, depending on the medication, is in the $20,000 to $60,000 range for one course of therapy. So the payers of this medication restrict access to make sure that the patients who are receiving the therapy are the best candidates for success with that therapy. And in the beginning, in 2013, when the medications first came out, access was very much restricted, and access has been slowly opening up as we learn that the medications, as the guidelines have come out saying that we should treat all patients, regardless of their substance use disorders, concomitant medical conditions, because the medications are safe and effective, and we can achieve cure and eliminate this virus from our nation, but they still are pricey. And so the payers just want to make sure that the patient's going to complete the therapy, that they understand that it needs to be taken every day and that sort of a thing. So they make you jump through some hoops in order to get that approved.
So is there a compromise, or how can you address the prior authorization without it going, full on, how we can't control the cost, so
Yes.
that there can be, when it's needed, provided?
It's again, Heather Lusk will be addressing this, but the real quick summary is that the MedQuest organization is going to allow primary care providers to treat hepatitis C in uncomplicated patients without specialist consultation if they can show that they are adhering to the guidelines that Dr. Sai mentioned, and if they've completed some training in the treatment of hepatitis C.
Thank you, Chair.
Okay, House, any questions?
No, does she have?
I do. I have some things to present to you. If we're ready, I'll go ahead and move on to that.
For Dr. Sai. Any questions for Dr. Sai?
No, but if Dr. Sai, if you could stay on, and let's listen. I don't think there's any.
Yeah, that's good, because I think we have a bunch of questions, but we don't know who to ask it to. So I agree with that. If both of you who are on Zoom could stay on. So any questions regarding what we've heard so far? Okay, so Dr. Baumgartner, please proceed.
Okay, thank you so much. It is my great honor and privilege to be able to speak to you today about one of my great passions, which is caring for patients for hepatitis C. I was able to be under the mentorship of Dr. Sai to start a pharmacist-led hepatitis C treatment program at Hawai'i Island Community Health Center in 2019. Next slide, please. And we've been speaking a lot about the intersectionality of opioid use disorder or other substance use disorders and hepatitis C. And so today I'm going to speak with you about the HERO project, which is the health enhancement to reduce opioid use disorder. It was funded through the Department of Health State Opioid Response Grant and started a couple of years ago in the spring of 2019. Our health center was one of the early participants with this project. And the goal of this project was to look at that intersectionality of those two disorders. So looking at care coordination for screening of patients for hepatitis C for treatment and cure, and then also looking for referral for patients who have opioid use disorder for treatment for that. So looking in both directions. Next slide, please. The folks who are involved in this project, there are 5 different service provider types across 3 islands, which reaches that goal that the Department of Health had for community resources on neighbor islands and bringing all of that together. So you can see all the different provider types that are involved in the project. Next slide, please. So we've talked a lot about, kind of peripherally, about opioid use disorder, and one of the senators, I think, was asking about the prevalence, because we were talking about how hepatitis B is more prevalent in Asian Pacific Islanders, and you were asking about hep C. It is more prevalent in patients with opioid use disorder. So 1 in 10 persons with hepatitis C also is diagnosed with opioid use disorder. And this data comes from a study that was published 2 years ago, looking at 1.3 million patients in 5 states on the continent. But that data was actually from 2014 to 2016. So it's actually old. The prevalence may be even higher if you consider the increase, the great explosion we've had in opioid use disorder, particularly with fentanyl, in the last 3 or 4 years with COVID. So what did we do at our organization? We already had, as I mentioned, established a hepatitis C treatment program in 2019 through a partnership with the Department of Health. Some of that, $75,000, helped to fund some care coordination at our organization. And we also already had an opioid use disorder treatment program in place at our organization. So this project brought the 2 pieces we were already doing together. So we looked at all of our encounter data every month, looking for patients who had an opioid-associated diagnosis, and then looked to see, were they screened for hepatitis C? And if they had that opioid-associated diagnosis, were they also referred for treatment for that opioid use disorder, if it was in fact an opioid use disorder, because patients who had an opioid-associated diagnosis may be taking an opioid for a pain indication. So looking at that, this data that gives us the prevalence of opioid use disorder in patients with hepatitis C also shows us that patients who have OUD and are treated for it and have hep C are more successful in their hepatitis C treatment if we also treat their OUD. When we looked at our results after the first 2 years of the program, we had 224 patients who had an OUD associated diagnosis who were referred for treatment, and of those patients, 181 received therapy for their condition. Next slide, please. This is the meat and potatoes of our project on the hep C side, and this is a traditional care cascade for hepatitis C. So remember, as our colleagues have mentioned, both the CDC and the USPSTF, they recommend screening for all adults for hepatitis C. So we have this big pool of patients who should be screened for hep C. Of those with an OUD diagnosis, we identified 308 who had an OUD diagnosis during this time period. Of those, 162 had been screened for hepatitis C at the time we identified them. So remember, we were looking monthly, every month we were checking in this. And of those 162 who were screened, 47 had a positive antibody test. And remember what my colleagues told you earlier, that hepatitis C, once you have it, you can be cured, but you will always have that antibody. We can cure the condition, but you can get it again. The antibody is not protective. So a positive antibody just shows us that they've been exposed to hepatitis C. It doesn't tell us if they have an active infection. That's where we do a second test to see if the virus is in their blood. That is the RNA test. So of those 47 patients, 31 had active hepatitis C infection. And of those 31 patients in the first 2 years of the HERO project, we were able to treat 22 of them. Reflecting back on the earlier data, you may recall that 1 in 3 in our nation, patients who are identified with hepatitis C, achieve cure. And cure is different than treatment. So as Dr. Sai mentioned, we do a test 12 weeks after we treat the patient to see if there's any virus in their blood. That's our definition of cure. And that means we have to get the patient to come back and get that test. And in this patient population, that is sometimes a challenge to get them to come back. So of those 22 patients we've treated, we've got 17 of them to get that test. So our cure rate right now, and all of them were cured. So our cure rate right now is 55%, which still kind of smashes the national average out of the park. So we're really proud of what we've been able to achieve in our program. But I don't want to neglect the other purpose of the program, which is not just to identify and treat patients who have hepatitis C infection, but to just let people know if they've even been exposed or give them their status. And so if you look at that second column, the 162, those were the patients who were screened when we identified them as having OUD. But that means there's a whole lot of patients who hadn't been tested. So what we did was reach out to those patients. And the HERO project offered us an additional small amount of money to give incentive to those patients to get their hepatitis C screening test done. It's hard to get patients to want to go to the lab and get their blood drawn. So during the course of these 2 years, we were able to incentivize 60 patients of the however many that hadn't been tested, get that test done. So we're also really proud that those patients who were at risk were screened. Some of them were identified as hep C positive and then were able to be treated. And I think that's my last slide.
Okay, thank you very much. Senator, any questions?
Yes, I have questions for the two doctors. If untreated, what are the additional costs that are taxed to the healthcare system?
Dr. Sai, you want to take that or you?
Yeah. For a person who have hepatitis C and is untreated, about 20% of them will then progress to a status we call cirrhosis, and they will then goes into liver failures. They either passed away or they would need a transplant. And for each transplant, the costs involved, financial burden is about $160,000 to $300,000, depends on their severities. And one of the most common reasons why a liver transplant occur in the United States is hepatitis C. Used to be about 1/3 of the transplant candidates are due to consequences of hepatitis C that was not treated. And the other more dreadful consequence is liver cancer. And the liver cancer, as we know, some of them is treatable and can be controlled, but many of them cannot be. And they would need to be transplanted, or if they are beyond transplant capacity, then they just passed away. So those are the consequences. And it's about 20% of all people who have chronically actively infected hepatitis C. Now, if you look at those people who also have other comorbid conditions, such as alcohol use problem, then that percentage go much higher. And I think that is a combination of problem that will be really not only the financial burden, but also social burden, because many of these people, if you see the graph that I show, is between 20 to 49 age people who are in the very high peak now. These are the people who ends up in 10, 20 years from now would need those kind of service. And that is a huge burden for the country and for the society as a whole. So I think the consequences is high, and you're not treating this patient with hepatitis C.
Any follow-up questions?
Can I ask a follow-up? So for a person who lives with cirrhosis, their quality of life, one, we've already heard they are likely to die 20 years earlier. But quality of life, contribution to society, are these individuals who are in some ways highly disabled?
In the face of cirrhosis, there are actually 3 different stages, A, B, and C. If you get to the point of hepatitis A, stage A, you still are functional most of the time. But when you get to the B or C, then they would have disabilities in the form of bleeding and ascites, which is the most common complications from cirrhosis. You see people with a huge abdomen and they cannot move around. They need to be tapped, they need to be given treatments. And in fact, they are commonly have to end up going to the emergency room to be treated for the fluid overload in your abdomen. It's a condition we call ascites. And then this can be happening every week, every month. So that's a burden not only for the healthcare system, but also for the family that we have to take care of those problems. So that is a burden in terms of cirrhosis itself. And when they get to the stage B and C, that they have to be dealt with. The other complication is a condition we call encephalopathy, which means that they become very confused and they were not able to function. There are medicine for that, but they will get into the point where they lost their consciousness, or they become very odd behavior that they have been taken to the emergency room. So those are the 2 most common reasons that cirrhotic patient ends up in the emergency room. And many of my practice is taking up a lot of these patients that need to be taken care of on a very long-term basis. So that's kind of the part of the cirrhosis, is the ascites, encephalopathy, and the bleeding. When they start to bleed, they will be ends up in the hospital.
Okay, thank you. And I think the reason for members, I think the reason why I want to know this is because it's an analysis we have to understand. What do we save by making sure treatment occurs? Even though it may be expensive on the front end, actually in the long term for the entire healthcare system, which we are subsidizing through Medicaid and Medicare and all of that, there's cost savings here. So that's why this is important. Thank you, Doctor. Thaddeus, did you want to add anything?
I just want to add that we're currently in talks with one of our research partners on doing economic modeling for cost saving for Hep B and Hep C also. So as soon as we get that, we can share that with you.
And what I would add is, because I'm looking at your paperwork, right? So we have a statistic, 1 in 4 individuals in our prison systems has hepatitis. That's a cost that we absorb. Treatment for them is what we absorb. And now as Medicaid is looking at making sure that we have coverage for justice-involved individuals who are coming out of incarceration, that is absolutely the best time that screening and connection with care coordinators should and can happen, because then it'll reduce the burden across the board, right? Okay, so I think we're on the right track. Thank you, sorry for interrupting. Thank you for the questions, Senator.
Yes, so I have a bunch of questions, and I don't know who to ask, and whoever it is could move up. I want to know a breakdown of Hep A, Hep B, Hep C, prevalence in the state of Hawaii, percentage-wise, because whereas my colleague wants to talk about consequences, I want to know breakdown, because we're talking prevention, right? So Hep A, percentage-wise state of Hawaii?
We don't have any cases currently, right? So
0.
hepatitis A is acute, so once it's resolved, you have natural immunity, unless you have some other co-occurring condition. But currently we have no cases of hepatitis A.
Okay. Hep B, that's the one that's prevalence with an Asian Pacific Islander.
Correct. And
What are we talking about?
Well, with Hep B and Hep C, as Tim mentioned, there hasn't been funding for surveillance, so there is no number that we can give you. We can all we know is that mortality number that we're able to share with you.
We don't have surveillance.
So we do have passive surveillance, so there's electronic lab reports that come into the health department, but there hasn't been a funded position, at least since I've been in this position for 12 years, so there hasn't been dedicated persons to analyze data and to create prevalence.
So how do you know it's prevalent in Asian and Pacific Islanders when it's
So-
only when it tests positive that you?
So
Find
the
out.
data that Tim was sharing was US data, so we do have that data, and then we have small scale studies with like, for example, Kalihi Palama Health Center, we do show higher burden, around 8%, among especially our Pacific Islander patients. So we can kind of see the bigger and the really small, but we don't have the statewide because we never had funding for that.
And that's also why we don't know on a granular level.
Exactly.
Asian and Pacific
Get
Islanders
it?
are lumped together along with Micronesians.
In federally, yes. In Hawaii, luckily, we are able to kind of tease that apart more often. And so, for example, the health center data I mentioned, we're able to look at country of origin. So we were able to see like Marshall Islands, Chuuk, Korea, Vietnam, and what we're seeing, at least in Kalihi Palama Health Center, among those that we were able to get data for, that there was about an 8% prevalence for our Marshallese and our Chuukese communities. So much higher.
Are you folks gonna be asking for monies for surveillance?
We got some from the CDC, which is the position, but I think Heather will be making some policy
Okay,
aspects
on
of
that,
yeah.
okay.
Let me answer
Yes, go ahead.
your question. Number one, you mentioned about hepatitis A. I think that there is a hepatitis A vaccination program that is very completely covered in children's. So I think several years ago, it became a benchmark for all the pediatricians to give as part of the vaccination program for child. So that generation is probably not going to be a problem. And the problem that we have to is to catch up those patients or those people who have never been vaccinated. So that's part of the effort that we have to do. Now for hepatitis B, I did a survey back in 2003 of about 4,000 people in the state. We go through different communities. The data that we gather is about 3.6% across the board of the state, but it's go up to 8% in certain ethnic group like Chinese and Asian Pacific Islanders have a higher percentage. But as an average across the board, a cross-sectional look in the population that we have back in 2003, that's about 3%.
Okay, but we don't know now, because we don't
We
have
don't know.
surveillance. And how about Hep C? None.
Correct, yeah, for both of those, yeah.
Okay, and Dr. Sai, you didn't do a 2003 survey for Hep C? No.
Well, I was able to get funding from commercially, and a lot of volunteers go to different communities. We went to the health fair, went to the Lions Club, I go to the Rotary Club, went to the church. So we was able to gather about 3,900 some patients that we were able to identify. And we started to do a vaccination program at that time with the help from the DOH because they provide me with free vaccines for hepatitis B
Yeah,
patients.
that's Hep B though, Hep B and Hep A
Yeah,
have vaccination, but
that's
not
for Hep B.
C.
Yeah, that's for Hep B.
Okay, so
Yeah.
here's my question. If we're gonna go for Hep free, how are we gonna start with a benchmark when we don't know where to start?
That's exactly our question too, and that's exactly why we have a position, we're trying to hire for that now so we can get those benchmark and get actual prevalence data that we can work off of.
Yeah, so we don't know whether or not we're progressing if we don't know where we started.
Right, so all we have now is the outcomes of mortality that we can show. So that data is available through the CDC death certificate database, but we don't know the actual prevalence.
Okay.
Yeah, that's exactly the question that we're always asking as well.
Thank you.
Thank you,
Oh,
Senator.
I'm sorry, okay,
Or Senator,
I'm gonna go
I
with-
have some
wait a
data.
second.
that-
Dr. Baumgart,
Gardner.
go ahead.
Yes. So we, as I mentioned, we actually have a grant for care coordination of hepatitis C care from the Department of Health that we've had for the last 4 years. And so I have, if I'm just looking at our data from 2019, 2020, and 2021, of the 62 6,215 patients we screened. 89 had a positive RNA, which is a prevalence of 1.4%.
Okay, so that is, the positive RNA is Hep C.
That's Hep C, and that's in our patient population
On
prior
Hawaii
to our
Island
merger.
Healthcare
So that's
Center.
when we were West Hawaii Community Health Center, serving only the west side of the island. And then we merged with Bay Clinic last summer. So now we serve 2/3 of the Big Island, 40,000 patients of a much bigger data pool. So I'll have better numbers for you next year.
Okay, thank you very much. I think Senator Moriwaki has a question, but I have more questions.
So
ahead.
just clarification on surveillance. So do you collect it, or has Department of Health collected data, but it's just not being analyzed, or is it that you don't collect it?
Correct. So there is data that is automatically reported to us from all the labs.
So you have
So it's
that.
passively collected, but you know, in order to analyze data, right, we need that person to duplicate everything to ensure that it's quality to actually make the estimate. And there's been no one funded to do that work, at least since I've been around for 12
So,
years.
but the data are there. So,
The data- so
is that
someone can
blood
come-
tests? Are they blood test data? What is the data?
Correct. So all
Yeah.
Hep C laboratory data will be automatically reported to the health department. So it's in the confidential repository. So that's Hep C antibody and Hep C RNA and some liver values that are related to that, and hepatitis B. The three tests that make up the panel are also reported.
So it's required for every clinical lab to give it to Department of Health, so it's there.
Right. It's in the
So you
admin rules.
actually can analyze it. All you need is epidemiology, I don't know, an
Yes, an
analyst.
epidemiologist. Correct. Yeah, that's what we're. Yeah.
To analyze it, to then give us a trend of, it's been forever there, you've been
Right.
collecting this.
Yeah. Exactly.
Wow, so all you need is somebody to do the analysis.
Yeah, they want
Yeah.
money.
Yeah.
75,000. Is that
Yeah,
what
we-
it, no, epidemiologists cost more than that.
Epidemiology, yeah, as you know, yeah,
We're
epidemiologists are
gonna,
more.
we're gonna find out.
All right.
But how was Hawaii able to do it then with their data if they don't have?
So they
So,
use the
Dr.
electronic-
Baumgarten, how much, I mean, did you guys have money for that?
So, Thaddeus, I'm going to let you answer the question
go
about the
ahead.
money part. I will just tell you that we, part of our grant from the Department of Health required us to report certain statistics that looked identical to the care cascade that I presented to you for the HERO data. So we present number of patients screened, antibody positive, RNA positive, number treated, et cetera, every month to the Department of Health, and we've been doing that since 2019. So the numbers I gave you were just from the spreadsheet that I give the Department of Health.
Okay, that's the spreadsheet. I have a little bit more questions. I just want to make sure I figured out the difference between A, B, and C. Transmission from Hep C is by injection, it seems to me,
Primarily
right?
blood to
Primarily.
blood. Yeah. So any blood exposure. So, for example, if someone were to tattooing, exactly. That was-
You can get that too?
Mhm. Yeah, especially tattoos outside of a shop or in a prison setting, right, where there's no clean
Right.
works exactly. So you can
And-
get it that way.
And also drug
And
drug
substance
use,
abuse,
right,
yeah.
substance abuse.
Mhm.
Hep B is mostly also through sex, inheritance, also blood-to-blood transmission, but not necessarily injectables.
Injectables as well.
Also.
So any blood-borne exposure for Hep B. So I think of B as baby, booty, and blood. So baby, mother to child, booty, sexual transmission, and then blood-borne. That's how I think of it.
Okay, and Hep A is touch and ingestion?
So Hep A is infected fecal matter getting into your mouth. So that's
Yeah,
why it's
ingestion.
really, so water, contaminated food or water is what we saw with Genki Sushi
Yeah.
many years ago.
That's why it's, okay. That's basically it. Any other questions so far? But I'm sure there's gonna be more, but we have, next up is Kenson Alik.
Good afternoon. Thank you for the opportunity for coming to speak. on behalf of our project, Micronesia Education for Liver Wellness. My name is Ken Senalik, and I'm from the Marshall Islands. I'm also a storyteller for hepatitis B. Micronesian Education for Liver Wellness program started by myself and my wife in 2015 to help out local Micronesian community be aware of hepatitis B. MELWEP, it stands for MELF. It's like a web fishing net. We all come together as a community. It's just like the web putting everyone together to help battle that disease. So it's like also building a home. We all come together to help one another. So that's MELWEP, it stands for that. Here's the picture of our community regionally project of education, and that is the pest treatment. We go out to meet with our community to talk about the disease and how we can help one another to support the spread, to support the stop of the spread. Here is the link to our program as well. The next slide shows some of the local barriers and solutions we come up with to help our community. It is important to talk about hepatitis B in our own language, including Marshallese and Chuukese. We also work with Department of Health, FREY, to create in-language materials, video, and more. Many people from our community do not know about hepatitis B. We started a talk story session in our own language and culture to make sure that it's appropriate to present it to them to be able to aware of the disease. We go out to the community, feel most comfortable sitting, gathering, such as in the church, parks, or sport events. We also find that is having some prizes and incentive can make more people come forward to listen to our session. Some people want to know more and want one-on-one support, like when we come to them, just answer the phone, call them, talk to them to do stigma, or can be other barriers that prevent them from wanting to know more or learn about the disease. We are able to support our community members in person and, as I said, through the phone. Many people have in the community reach out to us because when we meet few of them in the church, in the sport event, and they go out and talk to them about contacting us, so we are able to get call from them and talk to them more. As I speak more about Hep B, I realize my voice matters to many of the community members. Now I speak locally, but also at national conferences and when federal policy makers having meetings, and they invited us as well, just like today, and in the mainland as well. Capitol Hill advocacy program, and one of the senator from here, Senator Mercy Irona, we are able to meet her and speak to her. So that's conclude my short presentation, and I will be open up for any questions that you may have. Thank you.
Senator, any questions? House? Go ahead.
No,
Okay.
question.
My main question is percentage in Micronesians, do you know? Other than what was stated here, that Kalihi Palama came up with like 8%, but that's only for Kalihi Palama. But what about what you know, statewide?
Okay, the Marshall Islands prevalent right now is about 14%
14.
of the population, about 60,000 population of the Marshall Islands. So that was reported 14. So,
Okay, thank you.
Not a question, I just want to thank you. I mean, you're the quintessential community health worker that we need to get into served communities. So I just want to thank you for, being there to educate your community. And at the end of the day, it makes our whole community healthier. So thank you.
Yes, thank you. Okay.
Oh, comment, question?
What about Chukis? Do you have someone like you?
actually, my wife is with me, and
There
she's
you
also
go.
a public health nurse, and we team up. We start the project together in 2015, as I said earlier.
So you do at least those two islands.
Correct, the languages, yeah. And we are able to talk to them.
Thank you.
Okay.
Oh, and then sometimes I think people from Kosorai also have reached out to you folks. Yeah, so Kosaraian as well.
Yesterday, we met with the Australian community as well.
Okay. Thank you very much.
Thank you.
Okay, next up we have Heather Lusk, Executive Director of Hawaii Health and Harm Reduction Center. Okay, please proceed.
Thank you, and thank you, Kenson. Kenson's been a core piece of Hep-Free Hawaii since the beginning, Kenson and Rensley. So hi, everybody. Thank you so much, chairs, vice chair, and members of the committee. I'm Heather Lusk with Hawaii Health and Harm Reduction Center. Myself and Thaddeus founded Hep-Free Hawaii 12 years ago, and Hawaii Health and Harm Reduction Center is the fiscal sponsor. But I am here today talking more in my role as co-founder and co-director of Hep-Free Hawaii. And we often have called hepatitis a silent epidemic. Part of the reason why is not only does the liver not always let folks know that it's hurting. You heard from Dr. Sai, you could be quite down the path of cirrhosis. But we also call it the silent epidemic because even though we don't have exact numbers, we estimate at least 10 times as much hepatitis B and C than HIV in the state. And even though I would never want to decrease or bring down HIV pieces, many people have heard about HIV but would have no idea that we have 10 times the rate of viral hepatitis. So I'm here to talk about our 3 major policy recommendations. And yes, of course, funding is one, and you're probably really used to that. But to be honest, we're going to actually spend probably more time on number 1. So I'm going to talk about the pre-authorizations and our work with MedQuest and potentially a role for the legislature, given the history. There was actually a bill in 2007 that the legislature passed that addressed that. Secondarily, if you go back for 1 second, sorry, then we'll be talking about the state-funded program. Thaddeus has done an incredible job of leveraging a statewide program with only $75,000. You can only imagine what he'd be able to do if we could fund the program more. And then lastly, because of the overlap with opioids, we also believe that as the state determines opioid settlement dollars, that there's a real synergy, particularly with hepatitis C, that could allow even one-time infusion of funds to really help us get to Hawaii being hep-free. Thanks, Thaddeus. So as you heard from Director McCormick, the CDC does consider hepatitis to be a winnable battle, hepatitis C, and that's because it's the first cure ever, the first virus we've ever cured. So part of the efforts, not just in Hawaii, but around the country, is eliminating hepatitis, is lowering barriers to treatment. Because we can now cure Hep C, again, the first virus ever, and we now also know how to prevent it. Even though we don't have a vaccine, we know enough that through testing, we can then, again, cure hepatitis C. So there's a national group called the National Viral Hepatitis Roundtable, as well as the Harvard Center for Health Policy and Law, released a report card for each state. They've done it 3 different times, where they looked at what is the state of access to hepatitis C medications in each state. So actually, we've done it 4 times now that I mentioned. Our first time was a B-, and that was several years ago because the treatments were quite expensive still at that time, and there were also had more side effects, and many states were struggling with how, at the time, more like an $80,000 a year for a course of treatment. Then More recently, we got a D- in 2021. 2021, yes, which was a pretty marked. That's when we saw that states around the country, Louisiana and others, had actively worked to reduce barriers. So when we got the D-, Thaddeus and I and our coalition actively reached out to Director Judy Moore-Peterson and MedQuest Director or Medical Director Dr. Toma, and they were very receptive, met with us several times, heard our concerns about the prior authorizations, and really worked with us to develop a memo that then was released in December of 2022 to try to reduce the barriers to treatment. Let me just pause for a second and talk a bit about the pre-authorization. So at least at our center, and this is Aaron, our HEP coordinator over here, he's a real expert in this area as well. It can take anywhere from 12 to 15 business days to get approval to use a medication, even though the American Association for the Study of Liver Disease recommends everybody have access. And that might seem like a small amount of time, but given that we treat folks that are houseless, we might not find them right away. People may have other issues come up. And so we've definitely lost people to treatment because it's taken up to those 3 business weeks, to be able to get approval for treatment. But in addition to that, at times it's really impacted the workflow and ability to, as you heard from Dr. Baumgardner, providers got really, if they don't have someone like Aaron to do the pre-authorizations or have a fabulous pharmacist like Melissa, most practices can't afford to take the amount of time. And Aaron, I'm looking at, a couple hours of filling out the pre-authorization back and forth. So again, that if you don't have capacity, it's going to make it harder for someone to access this cure. So as I mentioned, when the D- came out and we worked with MedQuest, we were thrilled with the release of the December 2022 memo from MedQuest that basically said that we want to support treatment. And so what they're willing to do is to have a provider attestation. And that provider attestation would, once every health plan had that with a provider, it would get rid of some of the barriers, such as we talked about having to have a specialist if you're primary care, do a pre-authorization, as well as some other requirements. So we're really excited that we're moving in the right direction. And since then, the Viral Hepatitis Roundtable has rebranded Hawai'i as an A, given this new memo and hopefully more access. Unfortunately, since the memo came out in late 2022, we did a survey of, I'm sorry, Thaddeus, how many folks finished our survey? About a dozen or so prescribers. And we are not seeing any decrease in the barriers, meaning there's still pre-authorizations, we're still having trouble with the pharmacy level. Just this week, Aaron was struggling with one particular health plan that I don't need to get into the specifics, but it's again was a much longer process. It'll be about a month between when the patient first came in and hopefully when the treatment will come in. So the attestation has not been released yet from MedQuest, though we hear it's coming out. Dr. Toma met with you and I 2 weeks ago to share this attestation. And the attestation would again be like a one-pager where the provider says, I will treat in alignment with the American Association for the Study of Liver Disease. That if it is a complex patient, that I will still reach out to experts like Dr. Sai and get consultation. And then also I've had a training, and specifically we're really grateful that MedQuest is honoring the ECHO training as one of those trainings, that if you participate in ECHO, especially the 16-week series, that then you are considered to have been trained in hepatitis and no longer need that specialist consultation. So we do have a letter at the ready that has over almost 70 Hep-Free Hawaii partners and providers ready to go back to MedQuest and the governor if we don't see release of this attestation, but we're hoping that they will release this and make it easier. But to be honest, we want the pre-authorization gone because even though it's getting easier to work with the plans, now we're seeing a lot of pharmacy barriers, which is whether the pharmacist is on the continent, sometimes they want to talk to the patient. If the patient's houseless, they don't have a phone. We're just continuing to look at these hoops we have to jump through in order to cure people and save their lives. So the last thing I wanted to say here was that in 2007, the legislature in Hawaii did pass Act 92 that stopped all pre-authorizations up until Act 20 was passed in 2015, which put the pre-authorizations back in for HIV and hepatitis. Now, we do believe that we've had a very collaborative relationship with MedQuest. I don't believe we would need to go to a legislative route, but just wanted to put that on the table if we aren't able to get over these barriers, both with MedQuest, but in implementation of ensuring that it's easier to prescribe this cure than it is at this moment. So I'm going to pause here because I know that was a lot. And Thaddeus, did I miss any major points on that? I don't believe so.
I think the only thing is that grade D minus or whatever came out 22.
Oh, sorry, 22,
Yeah.
not 21.
Yeah.
Okay. Which again then facilitated the discussions, but again really appreciated that our MedQuest director really saw. In fact, she's on our listserv and she's part of our coalition, and I think really wants to support us and support the state in getting to zero hepatitis in the islands, because we can cure this disease.
Questions?
Yeah,
Senator
just,
Moriwaki.
Just, so why was the pre-authorization put back in when it wasn't there before?
That's a really good question. My understanding was that, especially back in 2015, we still had much more expensive agents that also had a lot of side effects. It was a longer course of treatment. It used to be 6 months or more. Now it's a lot shorter. So there was more concerns about completing treatment, adherence, things like that, because of the high cost of the medications. And so wanting to ensure again that folks were really were the appropriate candidates. At that time, even the HHS-HLT guidelines, I think, were still recommending that if they were drinking, not to treat, and some others. Now we have no barriers as far as the treatment guidelines, meaning everybody should be a candidate for treatment regardless of their substance use or other pieces. So those are my understanding. Dr. Tsai might know more, but that's my understanding of why it was, there was concerns about narrowing the access at that time.
So wouldn't there be less of a need for the pre-authorization now when you have the cure and
it's cheaper and it's shorter course and the side effects are much less, and right, and that we really just have to help somebody stay on typically about 3 months, and then they're cured, and then they can't give it to somebody else. We haven't even talked about treatment as prevention, that by treating hepatitis C, especially in people that are still at risk, we're also preventing new cases of hepatitis C, because if you don't have it, you can't transmit it.
So that's my other question. Is it transmittable? So what?
Once it's cured, it cannot. Once it's
But
cured, cannot.
Prior to it is.
Prior to it is, and it's
how
about
is-
it's about 10 times more infectious than HIV as far as the amount of concentration. So, and the Hep B is even more concentrated. So just a small amount of blood into the body through contaminated equipment, as Thaddeus mentioned, even before the blood supply. To be honest, one of the major ways people have had it, especially our baby boomers, is before 1992, the blood supply wasn't screened. And in fact, we incentivized people to donate blood by giving them money. And so we got more Hep C into the blood supply. So even things like military service, there's a strong connection with hepatitis C through the gun that used to give the vaccines, and they might have spread hepatitis, especially in Vietnam era veterans. So the other good news is that we are getting ahead of at least the curve of they estimate that 60 to 75% of folks are in the baby boomer generation. So we can test once, we can cure, and then we're POW. And then if we can keep access to things like syringe exchange and others, then we can prevent new people from getting it, which is why it can be a winnable battle.
So why are we having to go to attestation rather than just getting rid of
That I honestly, that would be a question for MedQuest, because that was why we advocated for full. There's now 25 states that no longer have a pre-authorization for
But it was
hepatitis
full
C.
before when it was a worse situation.
Yes, right. And we also have seen there's been a real worry, both on the micro level, like your Kalihi Pawamas or your health centers, and also on a state level, that if you open up the doors, people would be flooded. But that's just not happened on the continent. They've opened up the formulary, and the Medicaid programs didn't go bankrupt. The clinics started screening and testing and treating, and they didn't get overrun. So there was a worry that there would just be so many, and we just haven't seen that in practice.
Just one more question, circle back. What is the cost then of the treatment? Is it 20, you said 20,000?
No, not anymore,
What was it?
right?
No, it's about 30,000. Is it about 30,000?
Yes, it's still
Dr.
30.
Dr. Baumgartner.
It depends on which product is used, and if it's brand or generic. It does depend on both of the medications that Dr. Sai mentioned, one of them does come in a generic formulation that costs less, but insurance companies receive rebates, so they have preferred agents. So the cost of therapy, I really can't give you a firm answer. It's somewhere between 20 and 60,000, depending on which agent is used and who's paying for
So
it.
it's a long-term treatment, so what is the treatment?
No,
Three
it's
months.
not long.
No, it's only 8 to 12 weeks.
Eight
The
to-
whole
8 to
course of
2 to
therapy is
3
8
months.
to 12 weeks, depending on which drug is used.
Yeah, it's expensive, each drug is,
Okay.
rep,
Yes.
The whole course,
Chair
20 to.
Bellotti.
Sorry to interrupt you. Do you know if Medicare covers the treatment?
They do.
They do.
They also require prior authorization, and unfortunately, we can't control Medicare.
Okay, is there any chance that these drugs are going to be part of the conversations at the federal level to be part of the drug negotiations?
That's a good question.
I think possibly.
Great
because-
question, and I would anticipate the answer to that is likely to be yes, given that this is part of the federal plan to eliminate hepatitis, because as we've mentioned multiple times, it is a winnable battle. But I did want to add to the conversation about there should not be any restrictions. I didn't mention on my slide about OUD and hepatitis C that not only does treating OUD help improve hep C cure rates, but continuous substance use during hepatitis C treatment does not adversely affect cure rates. It's really important to note. That's why there should not be any restrictions on hepatitis C treatment at all. Even if the patient is using substances, we have multiple clinical trials, actual clinical trials that show it does not adversely affect cure rates.
And not only that, we have seen people cure their hep C and they get motivated for health. We've seen people whose HIV was out of control, they cure their hep C, they're like, wow, I can control it. Now they're on HIV medications. We saw somebody who cured their hep C and then he stopped smoking and started to address his heart and other issues. There is something about the feeling really empowered to take care of your health, and to be disease virus free can be really motivating for folks to address other health conditions, including addiction.
It can recur though, right? I mean, after you get cured, you can
Only if you're
get-
exposed again. So you'd have to be exposed again to somebody's blood that was, yes. And the reinfection rate is not super high when we've looked at studies of people, particularly people who inject drugs, but it can happen. Because again, the antibodies are not protective, as Dr. Baumgartner said. We are not close to a vaccine that I'm aware of at this time, because that's typically the way we get vaccines, is triggering an antibody response, and it's just not effective in this case.
One more question. For those who are receiving OUD treatments of some
Yeah.
sort or are in programs, are they automatically screened and offered treatment for hep C?
They are not, but I'm so glad you asked that, because we have a bill that was not heard last session that would actually do that. That was introduced by Jared Wadula at Narcotics Enforcement Division, but it was never heard. And it would require all opioid treatment programs to offer hep C testing. So I have the bill number in a couple of slides, I believe. So I think it's SB, is it 1394?
I don't remember seeing this.
That would seem to be like a really smart kind of
Yeah.
Um,
Yeah, so it was
standard
SB
practice.
1394, which I believe because of the biennium, it's still alive. And it was actually introduced by
I don't
by
know.
Director Radula.
HB, right?
Oh, I thought it was
It's
SB.
SB and HB. The HB 1096 and SB 1394.
94, yeah.
Okay, so
Okay.
it's both of our.
It's
Yeah.
both of ours. It
But
was
no,
not
so, but we would
brought to
love
our
that,
attention.
and also that's why, Director Radula, as the head of narcotics enforcement, supported this, because he believes that it would help, and because it would require at least offering of the screening, because of the high rates, as you heard, among about 1 in 10 people with opioid use disorder also has hep C.
SB 1694.
1394.
1394.
Yeah. It's on this slide that Heather.
Yeah. Do you mind going back to this? There we go. So, in all full disclosure, I was in Thaddeus's position before him, so I am a little biased. I just want to say that I was the hepatitis coordinator for 7 years prior to Thaddeus, and before coming over to Hawai'i Health and Harm Reduction Center. And I really do believe that Thaddeus does so he does statewide, I'm sorry, not just Thaddeus, but the whole coalition, but really spearheaded by Thaddeus, that there's a statewide response to hepatitis A, B, and C with only $75,000. But the structure is there to that if more money came in, I truly believe it would, not only would it be leveraged, but it would be effectively used, because there's been so much success with so little resources. So not only is that 75,000 utilized across the state right now, but we've been really blessed to not have a significant Hep A outbreak in our homeless community. In fact, I'm looking at Senator Moriwaki because she's been doing a lot around homelessness. Actually, you all have. But San Diego and other jurisdictions have had significant Hep A outbreaks because of the relationship to the fecal matter. While we had Genki Sushi and some others, we are not prepared that if we had an Hep A outbreak, I don't believe that we are ready for it. But by funding this program and continuing to fund Hep A vaccines, we'd be in better shape. Also, the testing and vaccination, the health department right now has been very supportive at helping people who don't have insurance or where their copay is too large, that the health department helps provide some point-of-care Hep C testing. So Aaron, for example, can take the finger stick into the field, test people at the van, and that's all provided by the health department. We could do so much more testing if there was more resources. And then lastly, vaccination. You heard that from Dr. Tsai around some of the issues with hepatitis B, that we can eliminate chronic Hep B if we have access to all the vaccinations, and then we can treat those that currently have it. While we can't cure Hep B, at least we can limit liver cancer and other negative progressions. So just really encourage you that even for another small amount, and thank you for what you said, Representative, 75,000 is not much, but yet look at how much has been done with just that small amount. Can you imagine even just having a few $100,000? I'm not saying to limit it to a couple $100,000, but how much more that this system could do with all of the pieces in place. And then lastly, we would like to, as I know the state is looking at and the county is looking at the rollout of the opioid settlement, given the strong overlap, we call it a syndemic, that when we've seen opioids use go up, we have seen hepatitis go up. Many of you are aware of the Scott County, Indiana outbreak. It's now, 6 or 7 years ago, but this was an area in Indiana, actually under Governor Pence at the time, that did not have syringe access, and over 200 young people got HIV and hepatitis within a 6-month period because that's how quickly. So there's been look at Hawaii for what is our risk of an outbreak. And we have been deemed high risk by the Center for Disease Control of a potential outbreak of hepatitis C because of whether I look at Puna and the injection drug use. We know there, Senator, that's one of our highest rates of people who inject drugs is in that area, or whether it's other people throughout the state that don't have access to testing and treatment. We have been, what's not the word, certified, designated, determined to be a state that's at high risk. The reason I bring this up is that also would allow the state to utilize state federal resources to support the syringe access program. And so, and then as I mentioned, the two bills. So just really appreciate an opportunity to highlight the removing barriers to treatment, funding the state hepatitis program, and if appropriate, including hepatitis in the opioid settlement funds, to really try to take an opportunity to raise the awareness so that we can get closer to getting Hawaii hep-free by 2030.
Okay, thank you very much. Any parting questions? So I just want to make a comment. I really do appreciate all of you folks for coming here. I do remember when Hep C first treatments came out, they were super expensive and
toxic.
Yeah, toxic. And basically from the people I've known and I really couldn't quite figure out how people on MedQuest were able to afford it, because it was super humongously more expensive from what I knew. Somebody who was a multimillionaire, and that's how he was able to afford it. But he was also tested regularly because you couldn't be on drugs. You couldn't, you had all of these preconditions that prevented you. So it seems to me that you folks have gone far since then. And I thank you folks for all the work you folks have done. But you know what, that bill, SB 1394, see whether or not we can fix that, or the HB version. I really want funding for the survey. I really want
for
to
surveillance,
know
yes.
surveillance. I really want to know base where we are. That way we know how much progress we're doing, or how much, or whether or not we're actually devolving,
Yeah.
or not we're actually failing. And if we could do it on the micro level, that way we know how to target each community. And I really appreciate the Micronesian group that came here and doing an outreach with their community. We need, depending upon which community, it's highly prevalent, and we're going to need to have advocates on those communities, right?
Yeah.
Okay. Yes, Representative, oh, go ahead.
You mentioned that you have $75,000. Maybe you could use a couple $100,000 more. What is the high-end and low-end ballpark for how much more you could use?
Wow, that's a great question. So the ceiling would be, I just wouldn't put a ceiling, but if we could increase, like if we could get 500,000, that could really support more care coordination, more like coordinating with all the different folks who are really helping people link to care, and ensure that we have ongoing testing and vaccination supplies for all of our community-based agencies. Because a lot of things that's covered, we just
Is
try to-
500,000 the low end or the high end?
That's the low end.
That's the
Yeah.
low end.
I mean, I'm just gonna give you a number.
Okay, what's the
Yeah.
high?
We should allow them to go back and really
Yeah.
work
Yes,
these numbers out.
yes,
It's
yes.
not something we should commit up to right now.
Thank you for that. Appreciate that.
And I would like to see what the cost of surveillance analysis is,
Yes.
because I think
Yeah.
that as we've seen, it's really important to have baseline, so you've got to get
Mhm.
that
Well-
information up front.
And the good news is, as Tim said, that we did get CDC funding for that position, which we're currently hiring for now. We're interviewing this week.
Oh, good.
So there is, hopefully that will get us started for that baseline. And then they can help us estimate what other needs we would need in terms of fiscal support to get better data. Yeah.
Hi, I'm Diana Sullivan, the
Yes.
Chief of the Communicable Disease and Public Health Nursing Division. I do our budget for everything. It's just.
Can you come to the table, please?
Oh, sure.
Yes.
Thank you. To start, it's a full-time position, basically, to do the data analysis, to clean the data, to quality assure it, to then be able to present it in a way that means anything, to do the deep dives and such. So that's what we have available from the CDC on at least to start on a short-term basis, that we should have a person in that position.
So you've hired a
momentarily.
person, or you are in
We're
recruitment?
interviewing.
We're interviewing.
Oh,
Yeah.
that's good.
And we got quite a few applicants, which is
Yeah.
very exciting. So, but that is really the baseline for the surveillance. And then from there, it's really, the sky's the limit as far as what you can do with that surveillance and education and public outreach and such. So that's the position. And I will just add, while we're on positions, that the money is very helpful, and we need the money. And this program in particular is well positioned to use the money using our community partners. But at DOH, at least, we will likely need positions to go with it, because money is great, but we also need people to execute the money. Thank you.
I guess I'll close up.
Yes,
So,
go ahead.
comment on the bill. We probably going to have to rewrite the bill and just give it a little bit of a broader title. That might have been a reason why neither of us heard it. It's too.
And we're going to try and get opioid money for that too.
Yes, so we can work on something. I want to just thank everyone for doing this. I want to also say that, can you provide us with all of the presentations that
Yes.
were done? Because there was a lot of really, really good information throughout that we don't have in our packets.
And we couldn't read it from this far.
Yeah, my staff wanted me to say that your report is available online. It's going to be linked on today's hearing notice to the info briefing material. So it's really important for you to provide that to us so that we can then share this great information with others in both of our houses. So thank you again. This has been really educational, and I want to thank all of the work that all of the community partners have done, because we know that you folks really are the boots on the ground getting work done. So thank you to all.
Thank you for taking a
folks.
priority today. We know you have a lot on your plate and really appreciate. We've been waiting for this for probably 12 years since we started the coalition. And so just really grateful for you taking the time and asking such thoughtful questions.
Yes.
And better than that, we're going to follow up. So that's our commitment to you.
Okay, thank
With
you.
that, we're adjourned.
We're adjourned.
We're adjourned.
Thank you.
Go ahead.